Okay, I think we're recording, Jim.
All right, perfect.
All right, let's go. My name is Andrew Stickney. Been working with Jim for a number of months now with LX Medical. And Jim, I came across this article not long ago in the Star Tribune, and I think you can see it there on your screen.
Yep.
And it's talking about both a moment in time where it seems that Minnesota at large got a handle on the number of cases of COVID-19 coming about and has started to see somewhat of an uptick. And so, in going through this article, but then also doing a little bit of extra research, I saw that the total number of cases has just crested over 30,000, and the deaths just over closing in on 1,300 deaths, so about a mortality rate of about 4.2. And I was wondering two things. One, what is really going on here? So can you describe what it is you do with LX Medical, but also what is really going on here and what you're seeing in Minnesota?
Yeah, absolutely, Andrew, and all super important, right? To monitor the COVID-19 situation as we're getting more data live. This is all information really coming right from the hospitals and clinics as we're seeing the numbers. So this is all important for measuring. I am one of the co-founders of a group named LX Medical, and we're a completely mobile-based concierge in-home, urgent care, in-home medical care for the greater Twin Cities region. So we have seen our particular team really has been all the way from west of Minnetonka up to Stillwater on the east side, way up into the northern suburbs, and also all the way south, south of Apple Valley. And we have a pretty good sense for what we've seen for the types of calls we're getting, and the number of concerning cases for COVID-19, people with fevers and coughs and not feeling well. We've seen the uptick on our side and people's concern. And we also have a lot of our colleagues over the decades worth of experience that our co-founders have and our core team has. We've kept contact with our colleagues in emergency departments and clinics and intensive care units. And we've heard a lot of the information coming from them as well, as far as what exactly they're seeing in the hospitals right now during these upticks of cases we're seeing. And also, I think it's important to digest the numbers a little bit and what the numbers mean and how we're recording those numbers, all important pieces to the puzzle, I think.
So what are we actually seeing here? What is your interpretation of this data? What's really happening, and why are we seeing a spike in cases now in Minnesota as well as around the nation?
Yeah. So there's going to be two major factors, and I think these pieces of the puzzle are very easy to understand and visualize. So on the one hand, we have a much larger testing capacity, right? We have more materials, we have more companies who have developed tests to be able to do more tests on a day-to-day basis and get the results faster. So that's innovation in the space of COVID-19 that will continue to improve and become more efficient. So we can test more, therefore we're finding more, no doubt about it. Another thing to consider, although we've seen the uptick and we've just hit over 30,000, those numbers, and from that particular article in the Star Tribune, they're talking about active cases of COVID-19, which means a swab in the nose. They run that and they get the results back in a few hours or in less than a day in most circumstances. That test is not it's not a maximally accurate test when it comes to false negatives. So that means you got a swab, the result was negative, but you do actually have COVID-19. So the number is very likely to be measurably higher than 30,000. That's the nature of the testing, and that's true for a lot of different types of testing, including the statistics you see with influenza and the statistics you see with other types of viruses. There's a false negative rate associated with those kinds of tests. So it's likely more than what we're seeing. And on the mortality side as well. They're really trying to stick to confirmed cases. As far as that Star Tribune article was written, confirmed COVID cases that resulted in mortality. It's and so you invariably miss some of those because you're not capturing every single positive case. So we're getting larger numbers because we're testing better and we're getting better tests available to us. The other piece of it is basically since the beginning of June, restaurants have been opening a bit. It's very nice out here in the Minneapolis area and in all of Minnesota. And so people are out more, they're socializing more. And that's a part of this phase two that our leaders in the community and at the state level have allowed businesses to open, hopefully in a responsible way, to see how this summer goes as far as COVID-19 cases. The goal here was never to hopefully see that there's no more COVID-19 in Minnesota or nationally. Obviously, it's a very infectious virus. We've demonstrated it. It gets, it moves around very easily. People get very easily infected with it. But the real measurement here, and the one that we've been really, really focused on our team side, is not so much the number of COVID cases that we're finding positive. It's that mortality rate. How many people are having bad outcomes from COVID-19? Who are those people? What is that demographic? How can we protect them the best? I think those are some of the really interesting data points that are starting to emerge out of what is big upticks in COVID-19 everywhere, including on the national scale as well.
So that brings me to my next question. So are two things. Are you viewing Minneapolis as better prepared now to deal with this new uptick? So we're going to see it. Are we prepared for it? And then the second piece of it is, what would you recommend individually as people begin to reemerge into the economy? What should they do? Maybe just a face mask, maybe beyond the face mask, to protect themselves as we're thinking about those in our community more vulnerable, but also themselves and their families. What should they do?
Yeah. So to answer the first part of the question there, you want to repeat what you just said?
Sure. Better prepared to deal with it now than we were.
Yeah. So there is no doubt that Minneapolis, and I'll only speak for Minneapolis because this is where we operate out of. We have a lot of contacts in, far and above better prepared now today than back in February and March and April. There's no two ways about it. And that comes from how they've set up the hospital systems here and the emergency departments, and with their ability to have surges and be able to funnel patients appropriately through the hospital systems. People's access to being able to get into their primary care doctors is not as good as it needs to be yet, but it's improved now from where we were a couple of months ago. So much better prepared to handle more cases of COVID-19. And so that's been, I think, a big contribution to why that mortality rate seems to be slowly dropping, as opposed to the mortality rate increasing with the COVID cases. We have not seen that type of a connection, which is really important. That's an important data point to monitor, and to hopefully continue to see that mortality rate settles where it's going to settle, and hopefully will continue to settle lower than even what it is today. And it's much lower today than it was when you calculate out that mortality rate. It's lower today than it was a month ago, which is an important feature. If you look at the data points as to who is getting sick, again, this shouldn't surprise anyone. This is something that we've known really from the get-go, but it does seem to be a elderly, more vulnerable population, has a much higher susceptibility to bad outcome and mortality rate, or just really prolonged hospitalizations, decreased functionality, even if they do survive an infection with COVID-19. So you're getting into this. Go ahead.
To be clear on that, not a higher susceptibility to the virus, a higher susceptibility to it going very poorly.
Yes, you got it. 100%. Okay. I think what we're, everyone's immune system is a little bit different, right? And this is why when you have, 50 kids in a classroom, and influenza is going around that classroom, maybe in that particular classroom, half the kids get influenza and half don't, or maybe 5 kids get influenza and the other 45 don't. Why is that? That all these kids are sharing all the toys, and then the same thing with families with COVID-19. With what we've been seeing, someone has confirmed COVID-19. They were very sick. There's a family of 6 in a house. One other person has a fever for a couple of days. They feel okay, and the other 3-4 family members don't get sick at all. So there is an immune system question there, and that is more, data pending on that. Does everybody, does everybody get COVID-19 for the first time, and their immune systems just don't amount a big reaction, or is it that our immune systems are really quite advanced and they're very, very strong for most healthy individuals, and so just your ability to get sick is not as strong in certain populations. So yeah, I don't think there's any increased risk for who's going to actually get the virus, whether you're 10 years old or 110 years old. It's the bad outcome when you do get it, right?
One of the things you and
Yeah.
I have talked about, I'm taking us in a little bit of a different direction here, and this I would love you to dive deep on. You've talked about there's multiple layers of COVID shutting down the healthcare system and the effects of the second tier and third tier of the healthcare system that we don't necessarily see. We don't necessarily read about as much. And some of the stories are coming to light. Can you talk a bit about that?
Yeah. So there is of equal concern to COVID-19 upticking and mortality rates is what we've all been suspecting that we were probably going to have to deal with even a few months ago when this was all starting, is this second layer and third layer of complications where people are not, the average person, they're just not having the access to healthcare that they have had leading up to this pandemic. And what I mean by that is people not getting their physicals. People feel a little bit off, but they can't get in to see their primary care doctor, so they sit on it and they don't do anything about these early symptoms of larger problems. Heart attack, the percentage of serious heart attacks that they've seen in hospitals is way down percentage wise. And that's not a feature of people aren't having heart attacks. That's a feature of people not going into the hospital when they have chest pain. So there is tiers now of delay in diagnosis that we are seeing an uptick in that in our hospitals as well. People who probably would have been able to catch something early on, and now they have a much larger, more complicated problem that puts them in the hospital alongside the COVID-19 uptick. And it's not that might be as equally complicated right now in what we're seeing right now today, this summer, as complicated a problem as COVID-19 itself is what is all of these other cases of kind of like this healthcare neglect, in how this is playing out so far. And our colleagues in the ICUs and EDs, that's really what they've identified as one of the more frustrating features of what's happening in June. It's planning for the surge in COVID while there's all these actively sick people, non-COVID cases that are starting to swing up, of what's been shaking out of the illness tree in the last couple months that everyone's been hoping, well, hopefully these symptoms are okay.
The illness tree, huh?
Yeah, right, exactly. There was a colleague of ours had seen an individual who tripped off a low lying roof. They were getting the gutters cleaned out for the spring and felt fine. Like, didn't think there was any big enough problem to go risk getting COVID-19 at the ER. And they did a telemedicine visit. And over the telemedicine visit, the person seemed okay, right? They seemed relatively healthy, and they had probably downplayed their symptoms a little bit. And so weeks went by, and all of a sudden really not feeling well, and the leg was really bothering this person. They're having trouble walking. So they went to the hospital, and a colleague of mine saw this case, and this like unbelievable, like broken bones in the leg that were now not going to heal well. And there was a deeper injury in the abdomen that required general surgery at that point, but something that they could have avoided that at the beginning. I mean, like the healthcare cost on that, I mean, unbelievable. And then the individual cost to people having to make really tough decisions on, boy, I can't easily get into the clinic. I'm being, I don't want to go to the ER because of COVID-19, so I'm going to ride this out. And that doesn't generally go very well, right? Our healthcare system is based on having as good an access as you can have. And right now the access isn't very good. We're seeing it.
Got it. So last question, and then we'll wrap up here. But what do you see? What do you see the summer and early fall looking like for the Twin Cities and COVID? And what are you advising people to do?
Yep.
I know you guys have a lot of members and a lot of patients that you're seeing on a daily basis for urgent care.
Yeah.
What are you telling them once you go to their house, test them for COVID, that sort of thing? What do you tell them to do beyond that?
Yeah, good question. This summer, we're going to see more and more positive cases. That number is going to grow. And here's a great number for you. So basically up through June 1st, and these numbers start in February, we had about 1 million cases nationally of COVID-19, confirmed cases, through basically February to June 1st. From June 1st to today, another 1 million cases positive. That doesn't mean there's been this huge catastrophic upswing in COVID-19. It is just that we're testing more and people are out and about more. And those two things together are combining for way more data points. COVID is in the community, it spreads around. And so that's where those huge leaps in numbers come from. What we hope to see, the mortality rate stays low and stays trickling low, and then identifying the vulnerable groups. And this is the elderly, more vulnerable individuals are the ones suffering the most. And younger, healthier populations are not anywhere near as bad as far as suffering from really bad outcomes with COVID-19. And so what we have told our members of our services, and what we encourage them to tell their friends and family, first of all, if you feel sick, especially viral type symptoms, fever, coughing, body aches, you just really are feeling totally wiped of your energy and it's very unusual for you. First of all, you definitely want to let someone know, because maybe it's COVID-19 and that should be thought about and diagnosed, and to stay at home until your fever's gone for a few days. That self-quarantine stage is still pretty important, I think, overall. But in the scheme of, well, I don't feel very well, and so I'm just going to ride this out at home, that's where people are running into problems, because maybe it's not COVID-19. Maybe something else is going on that needs an evaluation. And so our team's been going out into people's homes and seeing tons of those types of cases. People want to know, is this COVID-19 or isn't it? And we're a fairly new business here in the Twin Cities. And so this hasn't been an option until now. And so we're trying to offer that as much as we can. That's the goal of our company, is to deliver really high quality medicine into people's homes at a concierge level of quality, right? So call your primary care doctor. Try to get yourself a telemedicine visit. You can call us at LX Medical if you live in the greater Twin Cities area, but get evaluated if you're not feeling well. Right? That is important. The vulnerable and the elderly. I mean, this is a really important point I want to make sure I kind of hone in on, right? It's great news that as someone in their mid-30s, relatively healthy, if I get COVID-19, chances are I'm going to do okay. I take that and I say that's good news for me. But I also really try to, every decision I make on a day-to-day basis, I remember that there is a very large population of people who are north of 65, and even more so if you're north of 70, 75, that they are really vulnerable and susceptible to this viral infection, and there are things that I can do to protect that group of individuals. And that is there's a layer of depth there, just at a community level, at like a humanity level. There are things I can do to protect someone else, and why would I not do everything in my power to do that? And that doesn't mean we need to stay self-quarantined for the next 12 months. People need to be able, for their mental health, their physical health, their spiritual health, people need to be able to get out there and go running, to safely socialize with social distancing protocols, and to ease into this summer. I mean, again, I don't tell people stay in your homes or stay in your property, try not to see people. I think that a part of this phase 2 experiment of this pandemic is getting people back out into their routines, getting people back into work, allowing people to be healthy outside of their house. But there are some really basic things that we can be doing while we're watching the data and watching the numbers and the mortality rate to protect the vulnerable and the more elderly individuals. And this mask wearing phenomenon of, should I wear a mask or shouldn't I? And you can't tell me to wear a mask versus I need to wear a mask 24 hours a day, 7 days a week. It really, for me, it just comes down to, it's a pretty small gesture for the protection of the vulnerable and the elderly. We're doing it for them, right? I don't necessarily wear a mask to protect myself. I'm wearing a mask to try to protect as many other people as I can, because it's so easy to do. So having a mask that you tuck in your pocket when you get out of your car and you're headed towards a grocery store, you can put your mask on. When you are out and about running errands, you can take the mask on, take the mask off when you're around other people, but have it available and ready to go. And that is going to help. This is a respiratory droplet issue, COVID-19, and the mask helps to contain it, to minimize the number of droplets that are coming out of your mouth and through your nasal passageways. It's pretty basic science there, and it seems to work, which is the most important thing, right?
Sure.
But again, I think a lot of people think, well, I'm not susceptible really to COVID-19, and I don't really care if I get it, so I'm not going to wear the mask. And although that end of it is not, it's not untrue, right? Less susceptible. Yeah, there are people who are way less susceptible to bad outcome. But just that memory, hopefully people can kind of trigger that. I'm not doing this necessarily for myself. I am doing this for a vulnerable elderly adult that I don't know, that I can maybe help minimize their risk while we're working on other types of medications that might help, which there's some good innovation happening for medications to minimize symptoms once you are infected. That's a conversation for another day. And then obviously trying to buy us some time to create a good vaccine without rushing one out too soon. So those things are important. Hand washing, always important, do it. But the mask piece especially, I think it shows that as a community, there's something you can do that is showing a lot of respect and a lot of thought for susceptible populations, who I think that's important for them to see that. Andrew, can you imagine if there was a virus and it predominantly was going to wipe out all men in their mid-30s, healthy men in their mid-30s, and then you found out that if everybody else wore a mask, including you, that your chances of getting sick were way, way, way lower, but no one cared. And no one really cared about about your demographic because it didn't affect them as much. I mean that would drive me absolutely nuts, Yeah. And we're not, and then we're not even talking about someone who could hop on social media and create a firestorm. We're talking about the vulnerable elderly people. You don't see a lot of 80-year-old people on the news who are vulnerable in this age group, right? And you don't see them on social media. They don't really have much of a voice out in front of people like you and I are potentially able to have a voice out in front of people. Sure. And I think that's a part of this. I think that's almost a part of the phenomenon. All of the people reporting on this and talking about this, none of them are in a high-risk group. They know people who are in a high risk group, but they themselves aren't. And so just this understand that the data, everything we're seeing with data, the people who are really suffering from this, they're vulnerable and elderly. We're supposed to be taking care of these people, right? So
That's incredibly well put. Um, all right, so let's wrap for there. Let's wrap things up there.
yeah.
And just plan to do another one of these at some point, because I think this is really interesting to be able to ask you questions and get you to sound off on them, kind of based on what you're seeing and the patient load you have and all those things.
Yep.
Anything else you want to share before we go?
I think that we covered a decent chunk, a decent chunk today. I think that this is like an age-old battle between elderly people and young people, right? It's always been there. They're always at each other's throats. Get off my lawn, stop playing football on my lawn. And the younger people say, oh, you don't get it. You don't get what it's like to be a teenager. This is a great way to bring these two groups together in solidarity, to do what we can for elderly populations. But yeah, no, and that's lighthearted way to think about it, and to put it. But there is a lot. There's a lot of good that healthy young individuals, young adults, teenagers, absolutely people who are going to and from work, who are healthy and able to go to work and return to work and be able to go have a mimosa for a Sunday brunch. They're able to do that now, which is great. But there's just some really safe practices that we can all very easily do for now, while we continue to compile data and numbers and watch what happens as we get more infections, which is expected. And at this point, the more infections we can get, the better. These infections are coming. It really just matters on the bad outcomes and how many people are being really negatively affected by it. And then you weigh that against the other layers of people having to neglect their health, and they don't want to be seen by primary care. So, just a few extra points there.
Really, really well put. All right, thank you, and I really appreciate you taking the time, and I'm sure the folks who view this will as well.
You got it, Andrew. My pleasure.
Thanks, Jim. See ya.